My dear students, in this video, I'm going to talk about hematopoietic lymphangioschistocytosis or HLH. It is one of the common manifestations with which patients in the ICU present, and a lot of times it causes diagnostic dilemma, and the treatment has to be based on the cause and the triggering factor and whether it is primary or secondary HLH. Let us walk along this case. It is a 23-year-old male, previously healthy, presented with high grade fever, abdominal pain, and progressive jaundice for the past 10 days. He was treated empirically for sepsis but continues to remain febrile, and there has been no response or recovery. The vitals, the blood pressure is 90 by 60 on noradrenaline, temperature is 39.8 degrees centigrade, heart rate is 128 per minute, respiratory rate is 32, saturation is 92% on rebreathing mask. On general examination, patient has jaundice, mild edema, but no rash. In abdomen, there is hepatosplenomegaly, and on CNS examination, the patient has a full score of GCS 15 out of 15. When we looked into the investigation, patient has a fall in the HB 7.8, a sharper fall in the WBC, that is 1.2 or 12,000, platelets 44,000. So there is a cytopenia involving two cell lines. Triglycerides are 480, it is very high. Fibrinogen is 115. Ferritin is 38,000. AST and ALT are 42 by 310, which suggests liver involvement. That is also suggested by a total bilirubin of 7.6 and LDH of 2000 with SIL2 receptor, or that is soluble 25 receptor of 9000, which is raised. NK cell activity low, and the Epstein-Barr virus PCR becomes positive. So bone marrow aspirate phagocytosis is seen. So in this case, it is very clearly, it can be guessed that this patient is having HLH because the bone marrow estimate is the diagnostic. So, in any ICU patient who has unexplained fever, who has cytopenias, organomegaly, particularly the liver and spleen, hyperferritinemia, as well as low fibrinogen, one should consider HLH as an alternate diagnosis. Although HLH is uncommon, but it can cause a lot of diagnostic dilemma, and unless one is able to solve the riddle in a careful logarithmic approach, it may become difficult to arrive upon the diagnosis quickly. Firstly, it can mimic sepsis and septic shock. It can mimic severe viral infections, particularly Epstein-Barr virus, dengue, COVID, and cytomegalo, macrophage activation syndrome, hematologic malignancies, severe liver failure and acute viral hepatitis, drug reaction or immune checkpoint inhibitor toxicity, multisystem inflammatory syndrome, thrombotic microangiopathies, aplastic anemia, disseminated tuberculosis, and leishmania. So you have to say mass or macrophage activations is also a syndrome is clinically indistinguishable, but this is often considered a subset of the secondary HLH, and it is more commonly found in patients uh, after autoimmune diseases. So, what is HLH? HLH is a life threatening hyperinflammatory syndrome which is characterized by uncontrolled activation of the immune system, particularly the macrophages and cytotoxic T cells, which lead to massive cytokine release, multi organ dysfunction, and a high mortality if untreated. There are two main types. One is primary or familial HLH, where genetic defects in the cytotoxic pathways are seen. So commonly they are PRF1, UNC13D, STX11, etc. And the secondary HLH, which is acquired HLH, that is triggered by infections, malignancy, particularly the lymphomas, autoimmune diseases, or drugs. So, a syndrome of excessive immune activation where the body fails to regulate the normal inflammatory response after an immune trigger like infection, malignancy, or autoimmune disease is what we call as HLH. So these are some of the common triggers of secondary HLH. One are infections, particularly Epstein-Barr, cytomegalo, HIV, H1N1, COVID, etc., as well as Leishmania is also responsible. Malignancy like T or non-killer cell lymphomas and leukemias act as a trigger. In autoimmune systemic, the arthritis, SLE, adult Still's disease. So these are important triggers for secondary HLH. And after transplant or long drug therapy or chemotherapy, the checkpoint inhibitors, post transplant immune activation, etc., need to be used. If you look into the pathophysiology, there is defective cytotoxic function of the NK cells and CD8 plus T cells, which lead to failure to kill the antigen presenting cells. The persistent activation of T cells and macrophages give rise to uncontrolled cytokine release. And thirdly, the cytokine storm on account of raised gamma interferon IL-1, IL-6, IL-18, and TNF alpha. So this cytokine storm is a hemophagocytosis, tissue damage, and organ failure process. So whenever we think about genetic HLH, we have to consider uncontrolled and ineffective immune response to the genetic HLH. So after activation, it fails to kill the target cell, fails to contract immune response, and therefore uncontrolled expansion of cytotoxic T cells remain unabated, and thereafter uncontrolled activation of the macrophages, giving rise to the picture of HLH also occurs. So this follows certain steps, and the steps from the cytotoxic NK cell or CT cell to target cell is a long journey, but it can be accomplished in a short period of time with the advanced gadgets. So whenever we think about HLH, we have to learn the diagnostic criteria. According to the HLH 2004, the diagnosis of HLH can be established if either one or two is fulfilled, like a molecular diagnosis consistent with HLH, diagnostic criteria for HLH fulfilled, that is 5 out of 8 criteria, and one can look into it. So H score is something which estimates probability of HLH patients based on the clinical and lab parameters. So next we have to know about the H score. So this is a diagnostic tool for HLH with a score of 169 or higher, indicating high probability of HLH, and this score is composite value calculated from various clinical and laboratory findings, which includes uh, and the laboratory findings includes fever, splenomegaly, cytopenia, and hypertriglyceridemia. And it has also been demonstrated that this is almost 93% sensitive and 86% specific. So when the H score is a powerful tool, that's it should not be looked upon as a standalone diagnostic method. So, what are the diagnostic strategies in all these patients who have either strong suspicion for HLH or who have been confirmed as HLH by the hospitals? So, when should you suspect HLH? One, wherever there is fever, cytopenia, and organomegaly. Ferritin count is very high, more than 10,000. Fibrinogen is low, triglycerides are high, and sepsis is not responding to antibiotics. So in the next phase, you apply the HLH 2004 criteria or the H score, and if more than 5 of 8 HLH criteria is there, it is the diagnosis is likely. If the H score is greater than equal to 250, then there is 99% probability of HLH. So once stabilized, the CHOP like chemotherapy for lymphoma initiated, and you have to consider for stem cell transplant after remission. There are certain adjunctive medications like ruxolitinib, which is a JAK1 inhibitor, For cytokine control, it is experimental use IVIG to modulate immune activation. So, before I end, the key take home messages from this talk would be that persistent fever with cytopenia and organomegaly not responding to antibiotics should raise the suspicion of HLH. Ferrum, that is ferritin more than 10,000, is the red flag. Malignancy associated HLH has poor prognosis unless underlying cancer is spreading is rapidly controlled. HLH can mimic sepsis but fails to improve with antibiotics. And bone marrow biopsy can differentiate primary bone marrow suppression from hemophagocytic activation. And last but not the least, early initiation of HLH94 protocol dramatically improves the survival. Thank you very much.